Good evening and welcome to the Charlotte Post Foundation's Mental Health Conversation. My name is Michelle Spears and I'll be your host this evening along with Linda Johnson. At this time, I would like to introduce our sponsor for this evening, Natalie Brown with Ally Financial. Natalie.
Thank you. Thank you so much, everyone, for joining this wonderful conversation this evening. At Ally, we share a similar mission to the Charlotte Post Foundation and championing efforts and making sure that we are connected to the community, listening to the community, and sharing great information. And for us at Ally, we're also here to help reduce barriers of economic mobility and providing people with greater access to education and vital services. So we're excited to be here today to hear this wonderful conversation. Our support of the Charlotte Post Foundation is longstanding, and Gerald is a dear friend, and so happy to continue to be a supportive partner of the great work that they're doing. We want to make sure that today that we lean into this conversation, that we hear and receive some of the great information that we're going to hear today around mental health. And so I'm excited to be here. Ally's excited to be a part of this great work. And so thank you all for allowing us the opportunity to lean in with you and to be a part of this great community initiative. Thank you.
Good evening, everyone. I'd like to welcome you for joining us this evening for a mental health conversation. My name is Linda Johnson, and I am a host along with Michelle Spears. Today, we are presenting a mental health conversation. We have Dr. Andrea Cochran and Dr. Russell Hancock, psychologists with Atrium Health, and we have Fonda Bryant, mental health advocate. Tonight's conversation, the impact of mental health in the Black community with the following topics: Blacks, mental health, and stigma. African American population and health statistics. African Americans and mental health statistics. 2020 pandemic and police violence. Community resources. And at this time, I'll turn it over to our co-host.
Before we get started this evening, I would like to invite you to open your chat windows and your Q&A, which are located at the bottom of your Zoom screen, as shown in this diagram. During this webinar, if you have any questions for our panelists, please type them in the Q&A window only, and they will be answered throughout the conversation. The chat window will only be available for our team to communicate the various resources of today's webinar and ways to support the Charlotte Post Foundation, with links directing you to the websites, subscriptions, newsletters, sponsorships, and donations. And if we run into any technical difficulties this evening and get disconnected for any reason, please log back in and we will resume the conversation. And that goes for the panelists and the audience. Thank you for joining us tonight and enjoy.
At this time, I'd like to introduce you to our team. We have Gerald Johnson, CEO, President, and Publisher, along with Herbert White, Editor-in-Chief. We have Aaliyah Bowden, Health Reporter, Nichelle Spears, Marketing and Events Manager, and Linda Johnson, Director of Brand Marketing Content. We are the team for the Charlotte Post Publishing Company. Thank you for joining us. And at this time, with no further ado, I'd like to turn it over to our publisher, Gerald O. Johnson, President, CEO. It's always a pleasure to have him with us. Gerald, it's all yours. Do you unmute?
Now,
Yes.
thank you for that introduction and that bouncing head coming up on the podium there. And thank all of you all for attending, and a great thank you to the panel that we have with a great discussion that we are looking forward to hearing, and for you to chime in and ask your questions as we go forward. Just a quick note about the foundation. This program that we're having tonight comes under our community education program, which is a social justice initiative where we are literally dealing with disparities in the areas of education, healthcare, crime, and other mobility, and its relationship to the African American community from a disparity perspective. And that tonight is carrying that forward with this webinar. But we also do corrective education with after-school programs in Title I schools, where we're helping young people who are struggling with literacy get up to speed with their reading and their reading comprehension so they can move forward with their education. We started this program to help with the dropout rate by the time they get to the 9th grade. We started this program with 3rd graders and carry it forward until we can get them up to reading speed. And the continuing education, we just do a program with highly, what's the word I'm looking for? Highly skilled and educated top African-American seniors in CMS High School. We just ended that program yesterday, as a matter of fact, for the year. And we just deal with African-Americans that are with the 3.25 or higher that apply to win a scholarship, but we celebrate them throughout the year. And so that's pretty much what we're doing with the initiatives that we have going on with the foundation. And again, I want to thank you all for attending. And we moved Natalie up, so we're moving now to the co-hosts or the moderators of this program. And there's another bobbing head. Herb White bounced up there as our chief editor-in-chief, which I always mess that up. And then Aaliyah Bowden, who's our health reporter. And the two of them will moderate this program, start the questioning, and allow you to chime in through the Q&A as we move forward. Again, thank all of you. I want to thank the panel again, the panelists again, and the moderators for making this program happen. And I'm looking forward to the conversation. Thank you all. Let's kick it off. Herbert.
Thanks for the introduction, Gerald, and good evening, everyone. My name is Herb White. I'm editor-in-chief at the Charlotte Post, and this is a conversation that has been long in the making. The Post has been at the forefront of connecting with the community, especially African Americans in Charlotte, for a long time, regarding health. And mental health has been at the forefront of what we've done in terms of reporting for quite some time. And these days, mental health is on everybody's mind, literally and figuratively. And just to throw some statistics out there to get us started with the conversation. And this is going to be a safe space where we can talk about mental health, the truth we will try to get to, and the myths, and we have experts on this panel who will help us dispel some of those myths. And this will also be a forum where you as an audience will get to ask questions about mental health, but maybe you were afraid to ask. So just, looking through some research beforehand from the National Alliance of Mental Illness, 1 in 5 American adults experience mental illness every year. That's a lot of folks. 1 in 20 adults experience serious mental health issues every year. 1 in 6 young people aged 6 to 17 experience a mental health disorder every year. Suicide is the second leading cause of death among people aged 10 to 34. So let that sink in a little bit, and we'll just start the questioning, the conversation, if you would, with someone who has been near and dear and has graced our pages and our website many times over the years, and Fonda Bryant, who is a mental health advocate. She does work in the public schools. And if you drive close to Bank of America Stadium at some points during the work week, you might see her outside with her sign that says, honk for mental health awareness. And Fonda can speak from firsthand experience about the importance of mental health and the advocacy that she's been involved with over the years because she's a suicide survivor. And Fonda, I guess the first question, and I'll toss it out to you real quick, is to kind of give us a little bit of your backstory in terms of how you've arrived at this point, from going to dealing with your own issues to being an advocate to help other people get themselves on track and to be more aware of others who may be facing those types of challenges.
Thank you, and I appreciate being here. One of the things that I have to say is that I'm very grateful to be here. I just celebrated my 27th year of being a survivor of suicide on February 14th. I'm a survivor of 27 years, but I want everybody to know it hasn't been easy. A mental health condition is not a quick fix. 27 years ago, I was struggling really bad. And the thing is that culture plays a big part into mental health, because in the Black culture, we've been raised, pray about it, don't claim it, give it to God. It's a sign of weakness. And that mentality almost killed me 27 years ago. And I see it every day as an advocate out here helping others. And so I grew up to a family. My mom was a single parent. She had me at a very young age. And I had no idea that I was suffering or dealing with a mental health condition. And I always tell people, if we do not have mentally healthy children, we're not going to have mentally healthy adults. And I should know, because I was not mentally healthy, and it took me almost down by suicide to get there. So 27 years ago, I was struggling. My son was 12 years old. I was working at Carolina's Medical Center. I was a pharmacist tech going into my 5th year. And one of the first things with depression, as everybody thinks, is always up here, but it hits you here and here, mind and body. It's together. And I was extremely tired. It was like every movement that I made, it was like walking in molasses. Like, molasses are really thick and heavy. And every movement I made took great effort. I was extremely tired. My appearance changed. I took great pride in my appearance, and I go to work and I barely had enough energy to take a shower, and people started noticing. My work started to suffer. I'm a pharmacist tech, and I had to be on top of the medications because at least once a week, I work with narcotics. So you had to be on point, and my work started suffering, and people started to notice. I wasn't eating. I would go 3 and 4 days without eating to the point my stomach shrank. And then when I would start eating, I would be in tremendous pain. And all I remember was I just wanted to go to sleep. I just wanted to go to sleep, not even knowing what was wrong with me. And then the stigma kicks in, because you don't want anybody to know that you think you're going through something, but you're not sure. And you sure don't want people to say you're crazy. That word bites people. It bites me in the butt as an advocate, and words hurt. So I kept it to myself and kept struggling. But thank God I had people at my job who started really noticing my behavior change, because I'm very talkative, very outgoing. I started withdrawing. I didn't want to talk to anybody. And I would just go home and take whatever energy I had left from the day and get my son ready for bed and help him with his schoolwork and feed him. And I remember being so tired one time that I would go to sleep in my clothes. And one time I went to sleep in my trench coat, because depression is debilitating. It's not regular tired, it's debilitating. It's the #1 debilitating disease in the world. It is also the #1 disease that can cause us to die by suicide. So for me, on February 14th, 1995, I just was in tremendous pain from the top of my head to the bottom of my feet. And I reached out to Hero. I sit on the state board of NAMI, the National Alliance on Mental Illness. And a couple of years ago, our walk, the theme was all heroes don't wear capes. And this is who this person was. I reached out to my Aunt Spanky. Her real name is Kelly, but her nickname is Spanky. My nickname is Tweety. And I reached out to her and I simply said, you can have my shoes. I don't remember much about the conversation after that. Now, she could have said, like I hear a lot of people, especially in our culture, say, they're just seeking attention. If that's the kind of attention we want, then you give it to us, because you don't know whether or not we're going to end up dying or not. She called me back and she asked me, was I going to kill myself? And I told her yes. And she went into superhero mode. She ended up having me involuntarily committed. And as bad as that day was, and as mad as I was at her, she saved my life. And I will always be grateful. And when I went through that, I realized the stigma, this with the stigma that comes along with mental health. Because when I went back to work after staying in a mental health facility for a week and went back to work, the same person, my director of pharmacy that sent me across the street to the employee assistance program to get help, was the same person that came up and whispered in my ear, hey, Fonda, you don't have to let anyone know you were in a psychiatric hospital. And I was really taken aback by that, because I'm like, I have never been ashamed that I have a mental health condition, because I knew it was physical. And I was taken aback by that. So I said, you know what? I got to help people. And I started being an advocate, but I didn't become a real educated advocate until I joined NAMI in 2014. And from there, I work with Mental Health America. I work with American Foundation. I have my own nonprofit. And, I really get out here and try to advocate, especially for our culture, because we're so far behind the 8 ball with mental health, because mental health has no face. It doesn't discriminate. It doesn't care if you got $5 million in the bank and live on the south side of Charlotte, $10 million and live on any side of Charlotte. It treats us all the same. And I want people to know that when you look at me, I'm not weak. I'm not selfish. I'm not crazy. I deal with clinical depression, a real physical condition that if we're willing to put in the work, we're willing to take ownership, we can get better, but it's an ongoing process, not a quick fix.
Yes.
Yeah, that's powerful stuff, Tweety. So, the things you learn, that's a good one. And so this is already off to a roaring start. So when this is for anybody on the panel, when you talk about mental health, and when you hear people talk about mental health, and Fonda made this point, you talk about crazy, or shell, or whatever kind of word you want to throw out there, adjective to describe what you think might be somebody who's having an issue, and maybe it's in a joking manner or whatever. But when you talk about words and how people are being described, is that, how big of a barrier is that? And is there a connection between hearing a word like crazy or nuts or cuckoo and it actually being a barrier to people seeking help?
Mr. White, can you hear me okay?
Oh, yeah.
Okay. So first of all, I want to introduce myself. I'm Dr. Hancock. I speak slightly on behalf of my colleague, Dr. Cochran. We are glad to be here to represent not only Atrium, to not only represent African American psychologists, but also as a part of the community as a whole. My answer to, or my response to your question is, I think we should do a little bit of a backup. And what I mean by backup is, let's define what mental health and mental illness is. And so mental illnesses, are health conditions involving changes in emotion, thinking, and behavior, or is a combination of all three. Mental illnesses are associated with distress, problems in functioning, social, as well as work and family activities, and it also includes substance abuse. But one of the things that I spoke with Dr. Cochran before we set up for the panel is that I really wanted to denote is, I want to clarify that mental health is not evil. And the reason why I say this is, if any of you all listen to the governor of Texas today talk about the shooting, he equated mental health with evil. And again, I and others are here to say that mental health does not necessarily equate to evil. I also here to say that people with mental health issues are not the only ones, or are not the reasons to all of the problems that are happening within our country, within our society, especially as it relates to gun violence. So I feel, as a mental health professional, as an advocate, to really put that out there that that yes, within our race, mental health has somewhat of a stigma, but generalities, that it does not necessarily equal bad things. And then the last thing I want to say is, at least when I speak on my behalf or the information that I'm providing, I'm not only going to be addressing as it relates to African Americans, but I really do think I'm going to try to apply it to all people of color. The reason why I think that is important is, basically since 2020, I think all of us as people of color have been experiencing ongoing trauma. And then yesterday's shooting only just reignited that. And if you look at the events that have happened in the past 2 years, especially as it relates to people of color, Black people getting shot, Asians being blamed for the pandemic, all of that has an impact on our mental health.
So Dr. Cochran, how about you?
Sure. Yeah, I'll add a little bit. Dr. Russell Hancock really did a great job of summarizing that. I would add that there's a difference between, struggling and going through a period of time where, things are just heavy and it's difficult to, you're experiencing some of the symptoms that Ms. Fonda talked about. There's a difference between kind of going through a period versus, and that would be more conditional, versus going through where it is more pervasive, where it's mental illness is more pervasive, where we're looking at something like these symptoms or indicators that are showing up in multiple areas of life. So it's showing up whether you're a student at school, at work, like Ms. Fonda was talking about as well, in relationships, in just various social spheres of life. So when there's a distinction between like a conditional or situational depression or anxiety or other mental conditions versus an actual mental illness. So there's a bit of a slight difference there. And definitely just what the panelists said, I definitely wholeheartedly agree. And also, as Dr. Hancock was saying, being able to look at mental illness and also look at mental illness through the lenses of culture, because that cultural overlay is very significant in terms of not only how we experience mental health, but it also, depending on what the treatment plans really, when we're talking about working through mental illness, or just mental situations that affect our mind, our bodies, our souls, or spirits, that's something that is going to look different through some of the different lenses. There's definitely some similarities, but there's definitely some cultural lenses that we need to be aware of. And Dr. Hancock was mentioning some of those, and he and I have talked about, just some of the, definite with police brutality within the African American community. That's been really huge. That adds layers of trauma, I guess, on top of the mental illness that people or mental health that people are experiencing. Also, just again, in different pockets of communities where you've got just basically layers of different things that are going on, that, and all of those can come together, culminating to create sometimes a very difficult and a difficult experience, especially I would say for people of color.
And just going off that, Dr. Cochran, racism is now seen as a social determinant of health for African Americans. So can you talk about how can racism in the workplace and society negatively affect a person's mental health?
Now, that is an excellent question. And so if you think about someone who, there's a term called microaggressions. And microaggressions, they're like the little insidious little things that more often people of color experience on a day-to-day basis. And I'm not saying that everyone can't experience microaggressions, but micro-racial aggressions, that is a common experience for people of color. It's, it's again, it's kind of insidious. It's those little sort of things that kind of that kind of just get into our worm into our brains, if you will. So so as people are experiencing just normal life, but then when you add on these racist sorts of attitudes and things that are just really baked into our societies, that are baked into our systems, and then and we're having to traverse though, all of those things and also being mindful of our mental health. The experience of racism and oppression and marginalization, that definitely adds a heavy burden on people of color. And so it's definitely, so as we're talking about mental health treatment and advocacy, we definitely have to look at things like racism, prejudice, oppression, and marginalization in our communities.
We just received a question from the audience from Valencia. She asked, would you say that there are degrees of mental illness, and is there anything that we can do before it gets severe? Anyone can comment. Dr. Hancock, feel free to jump in.
Okay, so do I think that there are degrees to mental illness? I'd say yes. So for example, one of the things when we're diagnosing, say, for example, depression or substance abuse, is we're identifying if it's mild, not medium, but mild, moderate, or severe. So yes, there are degrees to mental illness, to mental health diagnosis. With respect to what to do ahead of time, one of the things that I think is uncommon, and it's also unlikely, is that we as people of color should talk. And so you might not necessarily stave off mental illness, but what you can do is ahead of time is talk about topics, ideas, things that may be of concern. One of the things that we know in mental health or in these forums are that, for example, if you ask someone about suicide, the general public thinks, well, if I ask someone about suicide, they're going to have the idea. That's not accurate. It's important to ask to see where they're at. And so talking about mental health does not necessarily mean it's going to trigger mental health, but it can start an introduction to the talk. And if I may say one other thing with respect to the notion of racism. Racism for people of color is rooted in trauma. And one of the things that's important to know is that we as people of color, specifically Blacks, African Americans, we experience trauma different than others. I remember a few years ago, I was in a meeting with some white colleagues and we were presenting a forensic case and we were talking about a mid-20s young woman who had experienced some pretty hard things in her life. And one of my colleagues wanted to see if maybe we needed to do a trauma symptom survey, anything related to trauma on this individual because of what she went through. And one of the things I spoke up and said is that's an option, but it's important to understand is what many people of color go through does not equal the trauma that white people go through. And so what we consider just living from day to day would translate or can translate into trauma for others. And so we have historically dealt with trauma, but we've also processed trauma differently. And again, what with the things that are happening currently in society, I think it just further amplifies and reiterates that we are forever traumatized, and we continue to be traumatized by some of the things that are taking place. And again, and that traumatization then has a direct impact on our mental health.
Dr. Russell, you had mentioned that Black folks specifically process these aggressions and these traumas differently. How does that manifest itself? Is it drugs? Is it something else? Or, in your studies or in your practices, how does that manifest itself? Is there a way that it is more prevalent than others, or what?
The first word that comes to mind when you ask that question is denial. And the reason why I say that is I think oftentimes we minimize what we're experiencing, and we are in denial that we might have some concerns. You add to it, say, for example, you and I are men. And so we add another component to that. So I don't think that all people of color, especially Black people, I don't think we're in denial, but I do think that understanding mental health and understanding the things that's going on with us sometimes can be met with denial. Therein lies one of the things that Ms. Fonda brought up earlier, was the idea and the stigma of talking about it. We don't understand the level of our depression or anxiety sometimes until it's too late. And then again, you add in with that, substance abuse can be prevalent, and also substance abuse, although a mental health issue, can also be identified as a coping mechanism.
And I want to chime in and say that one of the things that I truly believe in, that we need to do a better job of talking about mental health within our history. Because when I had I only found out, or we usually wait until something happens bad, and that's when we find out that mental health runs in our family. Like for me, when I was taken to the psychiatric hospital, now my mom remarried and lives in Savannah, and I love her dearly. But if I would have had a heart attack or a stroke, my mom would have been on the first thing smoking up I-95 to check on her oldest daughter. But because it was a suicide attempt, because it was mental health, she didn't come. And when I talked to her on the phone, the first thing she said to me was, you need to be stronger. And that's the rally cry for us. So what, and then she also told me too, depression runs in our family. And I said, oh, it almost killed me. So one of the things I'm a big advocate for, we need to have these conversations. We need to talk about mental health, just like we do diabetes, heart problems, because you say, oh yeah, Aunt Sarah has diabetes. Uncle Bob has hypertension, which run rampant in our culture. We need to have those conversations about mental health. It's not a warm subject. It's not an easy subject to talk about, but we got to normalize it for our children, because I am at a high school where I see mental health on display every single day. I have students coming to me, Ms. Fonda, I'm struggling, self-medicating. So if we make it comfortable, or one of the things that I've heard from students at Charlotte Latin, where I was speaking last week, to Hopewell High School, same thing. They told me, Ms. Fonda, if I go to my parents and tell them that I'm struggling and want to get help, they said, what do you have to be sad about? What do you have to be depressed about? You got a nice home, you got cars out there. We gotta have these conversations, and we gotta educate people, because that to me is the biggest hurdle with mental health. It's breaking down that wall of stigma and educating people and dispelling the myths from the facts.
Mr. White, if I could speak up for a second, I just have one last thing.
Absolutely.
I keep saying that, but I'll have more to say. But I've never have just one last thing to say. But the other thing that I would say, in addition to concerns about denial, and I think Ms. Bryant is speaking to this, one of the things that I think Dr. Cochran and I have experienced multiple times in our clinical practice is that the fear in talking about this, regardless of what the dynamic of the person coming in, but the fear is of being vulnerable. And if you think about us, again, as people of color, we are more comfortable getting angry than we are discussing when we're hurt. And so if I express anger to you, that doesn't make me vulnerable, although it does. But if I express real hurt or concern or feelings of sadness and depression, that makes me more vulnerable in a way that we historically are uncomfortable with.
And especially when you bring that up, when you talk about men and Black men, when you expose yourself like that, there's always the whispers, oh, he's soft, he's weak, and so that's another layer of trauma that you have to go deal with. But that's a good word, denial. It ain't a river in this instance.
And the thing is,
can I just real
Oh,
quick?
go
I'm
ahead.
so sorry. Ms.
You
Grant.
go
So I
ahead.
was just going to say, I know we all want to talk, but I was just thinking, just based on what everyone is saying, I think part of having the conversations, we also are going to have to do some redefining. That has to happen. We have to redefine things like strength and what it means to be strong. Being strong does not mean being in denial. Being strong does not mean, repressing all or suppressing all of your feelings and acting like, things are not bothering you or things are not, affecting you in any way. And strength, like Dr. Hancock was saying, strength, I think if we more closely associate strength with vulnerability, and that vulnerability creates connection, and that connection is where healing can really happen. And so I think, part of having these important conversations, we also have to back up just a little bit and have some redefinitions.
Yes. And I will say too, also, you got to think about our history, like we're talking about trauma, and it goes all the way back to slavery. Because I remember my mom told me, we don't have mental health problems. We came through slavery, we're strong. So you think about it, mental health help was not invented for anybody but the rich, not even the poor white people, not even people of color. It was only invented for the rich. You saw when we were growing up, people going to sanitariums, and it was always rich white people. So then how did Black people handle mental health issues? First off, we were in denial and things like that. But one of the things that I even see now, it is more acceptable in our culture, and I don't use this terminology because I don't like people to be labeled negatively, but it's more acceptable in our culture to be called crackhead, alcoholic, drug addict, anything like that, except a person who goes to get mental health. I mean, look at Sha'Carri Richardson. Sha'Carri Richardson was struggling. She was dealing with grief. She lost her mother. But what did she do instead of going to get help and dealing with that grief? She started smoking weed. So again, and even with my father was a blues singer, the late blues singer, Johnny Taylor. I know my dad was dealing with mental health issues. And because when I got to see Unsung, they did a segment where he had to go live with my grandmother when he was 15 years old. And he also said he started doing heavy duty drugs when he was about 15. What happened? One of my dear friends is a trauma expert, said, we got to quit asking what's wrong with you and start asking what happened to you. And so something happened. So we've been dealing with trauma forever, and we're slowly starting to embrace mental health. But as long as that big S is up there, it's still going to be hard, and people still will turn to self-medicating instead of dealing with their issues and being vulnerable, like they said, to really get the help that they need.
We have a slew of questions that came in the chat. We can answer a few. The first one is from Maddie Marshall. She said, how is Alzheimer's and dementia classified? Is it in the spectrum of mental illness?
It's listed in our, so we have this manual, it's called the DSM, and we're in the 5th version of it. So the DSM-5, you will hear mental health professionals talk about that. Dementia is listed as one of the mental health conditions, and Alzheimer's being a subset of Alzheimer's being a subset of dementia.
Gotcha.
Because it is it's technically a brain disorder, so it's classified under a brain and psychological disorder as well.
It's important to note that as a psychologist, more than likely, we would not diagnose someone with that without some type of medical intervention, in part because although, yes, it is, as Dr. Cochran noted, it's in our manual, it really tends to be more diagnosed and more aligned, with a medical condition. And so we, as psychologists, would not just initially make that diagnosis, because there would be a number of tests and a lot of information that would precede the person coming in for us to give them that diagnosis.
Gotcha. We have a question from Karen Simon. She said, or asked, can you talk about the importance of finding the right therapist when seeking help?
I'll start, I guess. For me, I am a Black female, and I know I get a lot of Black people that want someone that looks like them, that understand. I deal with a lot of student athletes, Black males, and they say that. Me personally, I tell people all the time, go with who you're comfortable with, who you feel like is not going to judge you, and you can go in there and be open and honest and be able to work with them. I have always had white male therapists because I feel that's who I feel comfortable with. I have my first Black male therapist now, and we get along great. But I tell people, find who you're comfortable with. And if you go to that first therapist and it's not a good fit, don't give up. Go to that next one until you find that right therapist for you. But don't think that just because you're Black, you gotta go get a Black therapist, or you're Asian, I gotta get an Asian therapist, or I'm gay, I gotta go get a gay therapist. You find who you are comfortable with that you can open up to, so they can help you find those good coping skills that you can get out here and get on board for the walk of wellness and stay on that path. So that's just my 2 cents. I just feel like you need to find who you're comfortable with and who you can feel like you're not being judged.
Okay, so
And
go ahead.
I was just going to say and that is so very, very true. It of utmost importance. It's finding someone that you feel comfortable with, that you feel like is actually helping you kind of work through what you're presenting issues. There is some outcome data that says that people, when they perceive a type of similarity, whatever that may be, it doesn't always have to be along the lines of culture or race or gender, but when a client perceives similarity, they tend to have a better outcome because oftentimes they feel more understood. And I know as obviously as a Black female therapist, many of my clients that have come in, they of male and female African Americans who have seen me, they have been just really thankful for the fact that I am a Black female, and they've each sort of commented that they felt more at ease to be able to talk about their issues with someone who looks culturally or who looks similar to them.
I feel that therapy is like many other things in life, and that it's just about a good fit. So I do think that similarities can be important. And like Dr. Cochran, I have had people that see us somewhat as anomalies because you just don't have a lot of Black psychologists. But the other thing that has stood out to me professionally is not only about fit, but also making sure that the client is prepared and ready to work on their stuff. And it's not uncommon for people to think that they're ready, and then when they get in, they might find a reason that they may or may not like the person. Again, I believe that fit is important. I think that if you have similarities, that's important as well. But I also think it's important to know what your boundaries are, what your limits are, and if you are ready to do the work that's going to require to be in therapy.
Hey, now, let me throw this out here. In terms of mental health and holistic treatment, according to NAMI, people with depression have a 40% higher risk of developing cardiovascular and metabolic diseases than the general population. How important, or well, talk a little bit, if you will, about those connections between mental health and overall physical well-being?
For me, 27 years ago when I went through what I did, that was 1995, and all I knew was medication and therapy. Look at the things we have to do now. Well, number one, I work out 4 times a week. And that to me is one of the best ways. I love to leave that gym sweaty and my hair sticking to me because I know I'm sweating out depression. I know I'm sweating out the anxiety. Also, eating right. I read an article that said you can find antioxidants that help us a lot with strawberries, blueberries, raspberries, leafy vegetables, fish. Black people do not get enough vitamin D. Where is vitamin D found? In the sun. Get out and go for a walk. Music therapy, art therapy. We have so many things now. Coloring. I have 3 different coloring books. Who would have ever thought that coloring brings down your anxiety? So it's things now that we have to help us. It's not just about medication. And this is just my opinion. And this is what I tell people. medication is a tool. If we have to take it, we have to take it. It's no magic pill that's going to make everything better. Therapy. If we have to go, and I think everybody should go to therapy, just like we go for 1 year checkup for physical. I think we need to go whether anything's going on with you or not. But it's not a therapist's job to fix our lives. We have to pull from what we need from that therapist. And I have an imaginary mental health toolbox. And I take what I need from my therapist and I put in my toolbox. So when depression and anxiety are kicking my butt, I can reach in there. But the two biggest pieces for me are self-care. Knowing our triggers, knowing our boundaries, knowing who to put out in our life, knowing who to bring in. Like I told y'all, I love my mother. She's very judgmental and overbearing. So sometimes when she calls, I'm like, not today. And I'm okay with that because my mental health is the most important thing, because if I'm not mentally healthy, I can't do this work out here as an advocate. I can't help my son. Yeah. I can't even help myself. 27 years ago, I couldn't help myself. So you have to find those good self-care skills and coping skills to put in that mental health box. And the last piece I tell everybody, we got to have educated support. And I'm not talking about going to college. I'm talking about going to the NAMI website, Mental Health America, where they have every single mental health disorder listed. You can go on there and read about depression, anxiety. So you can learn, number one, is health. Mental health is physical health. And also the best way to help us and not enable us, because I take ownership in my mental health. I read on it, find out new ways, new things that can help, and helps me a lot, giving of myself to help others. So again, mind and body are together. I can't take my head off and set it on the counter until the depression subsides. It's with me every day. And my therapist gave me a great piece of advice one day. He said, Fonda, you have to make a conscious, deliberate effort every single day to take care of your mental health. And you have to be consistent. You can't say, well, this week I'm going to stay on top of it, and the next week I'm going to let it go to hell. You have to work on this every day, and it's exhausting. But if you put ownership, if you put in the work every day, I guarantee you, you can stay on top of your mental health. And I'm living proof of that.
And I would just echo Ms. Fonda, that was excellent points there. And I would echo everything that she said. And you know, if we look at how some of our medical models are, especially Western medicine, really tries to separate the mind from the body, from the brain, from the heart, you know, just like separate all these little pieces out. But really, we're, you know, as human beings, we really what makes us up is our minds, our bodies, our spirits, our souls, and then also our relationships, or, you know, collectivism, especially, you know, within communities of color. So it's nearly impossible. And I would say it adds to dis-ease when we try to separate things out. So I definitely, and there is a huge body of research and studies that talk about the importance of alignment within mind, body, soul, spirit, and relationships, or collectivism. So when we, again, Western medicine, I think, and I'm not, this is not you know, I'm trying to down Western medicine at all. Because I do think that Western medicine is coming back kind of full circle to a more holistic approach, but it's really difficult to treat a whole person without treating the person holistically. And it's very difficult to achieve wellness without looking at wellness from a holistic perspective.
Gotcha.
And there's another question. We've got some great questions.
Yeah, we sure do.
From Julia Paul. Thank you, Julia. With the alarming rate of youth suicides, what prevention programs have the best outcomes to reduce the attempts or completions?
Well, I'll go ahead and say it.
No, go ahead.
I don't want to feel like I'm just hogging things, but I am a certified QPR, question, persuade, refer, suicide prevention instructor. And when the pandemic hit, I decided to teach online, to train people online. And one thing I love about this training is the fact that anyone can save someone's life if they know what to look out for. So I started training on March 26th of 2020. I took a break in June, and then I started back training and trained all the way through December 19th of 2020, where I had trained over 1,000 people from 25 states and 5 countries who now can save someone's life, and that includes youth. I picked it back up again, and I'm still training. And I work at Hopewell High School, a school that has a great principal who also lets me train students. And the first year I started training, I had a high school student who took my training. And as soon as she got finished with the training, she got offline and went and told the school and was able to save her classmate's life. The only difference between the adult training and the youth training, we urge youth to go tell an adult. And if you give them the tools, if you educate them, they can save a life. So one of the things that I feel like I can share my story, we can have panel discussions, we can have all these things, but we got to start putting tangible things in people's hands so they can help someone to save someone's life. And the training is very upbeat, it's very positive, and it does save lives. So one of the things I truly believe in, education is one of the big things to save lives, because that training also dispels the myths from the facts. For instance, if you ask someone if they're suicidal, it does not increase the risk of us dying by suicide. If anything, it lowers anxiety, it gives us the chance to open up, and it gives you the chance to help. And I also tell people, no matter how you feel about mental health and suicide, when you're helping someone who's suicidal, you keep that to yourself. Because your job in that moment is to help someone to want to live and get them the help. So I feel like, me personally, that education is truly the key to one of the biggest keys to stopping suicide is educating people. Because when I train, a lot of people are like, I didn't know that, or I'm prepared now to help someone. And people that I've trained from youth to adults have turned around and saved other people. So for me, it's all about education.
And I butt in with a question right quick because I wanted to get this in early, and they wouldn't let me type it in because I'm on here. But let's talk. And you started this earlier with one of the conversations, but the community stigmas, especially with the church, in terms of how what's being said is impacting how people feel about this whole issue of mental health. Can we talk about that for a minute?
Ooh. Okay.
Anybody, all of you weigh in.
I'll speak up. I'll speak up that oftentimes, especially living here in the South, there is sometimes people will want a distinction between, are you a Christian counselor or not? Or they will often say that they went and got counseling through the church. So one, I do not identify as a Christian counselor, in part because when people are coming to me for therapy, they're not coming to me for my religious beliefs. That's one. Two, I don't down if anyone is seeking treatment, or not treatment, if anyone is seeking assistance from the church, but it's important to understand that clinically, the issues that they may be talking about within a church setting may not translate to what an individual may need from a church setting. And so clinically, we're going to be honing in on different things. We're going to be talking about their feelings, but we're also going to be going over historical data. And so it doesn't mean that they won't get that from someone who assists them in the church. But I do think that clinically, behaviorally, that the information and the approaches might be different, in part because they are in a community, meaning the church, where although yes, the information will be confidential, it's also not private. And that's one of the things that is beneficial to therapy is it's private. No one necessarily needs to see you come into the office. No one needs to see you leave the office, but it is private. And in a church setting, it just may not have that as a barrier to withhold the information that needs to be shared.
And I think one thing that we could do, and that's a great point. Those are great points. one thing that we could do, I think, more of actually leverage the church to do what Ms. Fonda was talking about, and that is a vehicle for education, a vehicle for awareness. So while the church may not be a place for people, or the church, or whichever spiritual practice or worship center that we're talking about, that may not be the place that people go to get therapy per se. It can be, and I've seen where it has been part of spiritual worship centers. But I think if we use it a little bit differently, maybe the church could actually be a place where some of those stigmas are refuted. Maybe the church could be a place where, you know, I'm saying church, I'll just say faith center. The worship center, faith center might be a place where if someone hears a spiritual leader talking about mental illness and normalizes mental illness and it is honest and vulnerable, even from a pulpit, I think we would get a lot farther if we were able to leverage that much more than I think we're doing. I think that is happening in some areas of the United States, certainly, but I have not seen that happen quite as much locally, and I have not seen that happen quite as much in our Black community places of worship as well.
I will say with NAMI, we have a faith net, and they are starting to get more in the churches. And for me, I've been training more pastors in QPR, suicide prevention training. To me, that should be just like they take CPR. They need to take QPR, and they also need to take mental health first aid. And one of the things I will say, I spoke at a Black church several years ago, and it really opened my eyes just to how long Black people been struggling with mental health issues. And I got finished speaking. I'm like, man, I don't know how they're going to, receive me. And the floodgates open. And these are people probably in their late 60s, 70s and on. And they were telling me, hey, I struggle with depression. I struggle with anxiety. I had a suicide attempt. And they told me straight out. I knew one of the reasons why they wouldn't go to their pastor because of the judgment piece. But one of the other big, and I teach that, I hammer that home in QPR training. You cannot be judgmental, because if you are, we're going to shut down and we're not going to say anything else to you. But the other piece is what both psychologists pointed out, is that they feel like that they won't keep it to themselves. They're going to tell the whole congregation and everybody's going to know. And I want to just read this real quick about, you talking about religion. So I saw where two pastors here in Charlotte obviously are not educated in mental health. They might be educated, but not in mental health. So this is what they said. Fresh vision chases away depression. Depression can't exist where fresh vision persists. Depression is simply caused by a constant focus on negative thoughts with no fresh vision or hope of change coming tomorrow. Now imagine if you're struggling with depression, anxiety, bipolar, whatever, and you go to try to talk to them and they're going to tell this to you. We got to change the way they talk to people in the churches, because I sent them what depression was. I sent them a picture of what the brain looks like with and without depression. They removed it. So until we get rid of, they took it down. So until we get rid of that ignorant something like this, we're going to still have these problems. And that's something that needs to change. The churches need to do better by people with mental health issues. They need to get educated, just like they get educated, as I said, on CPR. I asked a pastor one time, I said, if somebody came in your office having a heart attack or stroke, what would you do? Oh, I'm gonna call 911. I'm gonna get them help. We need that same help when we're in crisis or suicidal. We don't need you reading the Bible to us. We don't need you praying. You can do that when we're on the way to the hospital. We need that same sense of urgency when we're in crisis or suicidal as a person having a heart attack or a stroke.
If I may say, and I want to definitely piggyback off of what Ms. Fonda is saying, what she's saying and what I hear is that we, and you want to say this directly, we have to get comfortable, whether it be in the church, whether it be in clinical practice, but we have to get comfortable with talking about it.
Yes.
And one of the things that we know as people of color, especially as Black folks, is that we do not take things outside of the home. And so if you take it outside of the home, you are potentially, at least reputation-wise, potentially spreading business or giving people information that should not be shared outside the home. That is something that has to come down. And as we mentioned earlier, Mr. Johnson, that's a part of the stigma of not being able to talk about it, not being able to take your quote unquote business outside the home. But again, overall, more so than any of that is the ability to be comfortable with talking about the topic. And until we can get comfortable, whether it be in a church setting or not, it's going to make it difficult for any of us to be able to make progress, because again, it's dependent upon a person or persons feeling comfortable and being able to address what is going on with them, for, like, as both Dr. Cochran and Vonda said, without a fear of judgment.
Yes. Even with the EAP, when I was working at Duke Energy, and Black people knew that I was an advocate, and they would come to me and talk to me, and I said, hey, why don't you go to your EAP, your employee assistance program? And I tell them, hey, depending on the company, you can go see a therapist 3, 6, 9 times. Oh, I can't do that. I can't tell my business. And I said, listen, unless you're suicidal or in crisis, gonna hurt yourself or someone else, your company doesn't even have to know that you reached out to your EAP. But like he said, there is this fear of, I can't let my business go outside the door. And if I do, people are going to look at me differently. People are going to think I'm crazy. So he's right. Until we normalize mental health, we're still going to have these problems. As I told you earlier, Gerald, when we had that conversation last week, I said, you could give us Black people, and I know it's a big disparity with services and things like that, but you could give us free services for mental health, therapy, medication, and you would still have Black people who would not go get help because of the stigma. That's just how it is. It's a humongous hurdle to climb, and it happens every single day.
Well, and what to again piggyback off what Ms. Vonda is saying, it's fear-based. It's fear-based in addressing it. And I also want to say one thing that Ms. Vonda said about people, if the person is suicidal. We are mandated reporters, meaning we will only break confidentiality for one of 3 reasons: if a person is of imminent danger to themselves, imminent danger to another person, or if there's any reason to believe or suspect child abuse or neglect to an elder. Oftentimes people we all have to ask on the intake about substance abuse, and they'll give me a look, and I'm not the cops. I don't care if you smoke weed or not. And so it's important to understand the parameters of therapy. The only time someone, again, a therapist, a psychologist, a social worker would break confidentiality is by the rules of us being mandated reporters. Outside of that, everything stays in that room.
Yeah. And you got to realize something too. The media has a big hand in why people won't go get help. Because you see, when I start training, I ask people, I said, when y'all think of somebody with a mental health condition, what do you think about? What are the images that you see? Wearing a straitjacket, hair standing all over our heads. The image is really burning to people's heads. And that's what they think the perception is of. I've had people ask me, what's it like to be in a mental health facility? I told them it's no different than being in a regular facility. So again, when you have the media, you have, every time there's a mass shooting, it gets blamed on mental health. It just, like he said, it causes a lot of fear, and people will not go get help.
But the only thing that I would add to that is we keep talking about going out and talking to somebody about this, but that could also be just as dangerous, because you need to be talking to somebody that knows what they're talking about. And that's one of the problems I'm having with ministers, is that, again, ministers aren't trained for this. And so you can go talk to them, but doesn't mean you're going to get the proper information. So when you're going out talking to people about this and you're looking for help, you got to talk to somebody that knows what they're talking about, that's been trained in the whole 9. Y'all just can't go talk to anybody because they might be this or they might be that. You got to find somebody that knows what they're talking about, or you're just in deeper trouble by going out and talking about it.
Gotcha. We have a question in the chat from Patrice Johnson. She said, I see a lot of people on social media make comments about being at the end of their rope, and folks will comment, hang in there, stay strong. What are some things that can be done, steps to take when someone is making a cry for help? What is the best way to direct or help them?
You can actually have a wellness check done on someone online. I've had that done, a total stranger. You can, because Facebook, after they had some suicides that were online, they started changing. If you put words up like suicide, self-harm, anything like that, you can alert Facebook, Twitter, and they're going to reach out to that person. But I did learn this from getting somebody help that I didn't know. if they have their first and last name on their Facebook page or whatever page they're on, if they have their state and city, most of us have driver's license. So they can look it up that way and you can send a wellness check. But again, on social media, if you put in certain words or you feel like somebody's in danger, you can let Facebook know, Twitter know, Instagram, and they will reach out and get that person help. They will send a wellness check out.
And another question from Beatrice Burton. Beatrice was good enough to ask 2 questions. How different are the triggers for men and women? And the other question is, how can you help someone if they are in denial? Thank you, Beatrice. Anyone want to take a stab at those 2?
I think Dr. Cochran wants to get this one.
I will, how about I will take the because there's a difference between men versus women.
Yeah.
And then the other one is about denial. Okay, so I'll take the women part. I think women, we have been more conditioned to be in touch with a broader range of emotions. And so we are, I would say, just again, this is an absolute gender stereotype, but we tend to be a little bit more well versed in terms of what we are what's socially acceptable for us to be able to express. So I think for women tend to, kind of shut down a little bit more, tend to go inside of themselves when they're depressed, or they may do some outward kind of, I just can't take this anymore. Or just kind of drastic changes to their normal personality. I think those all tend to be warning signs, like Ms. Fonda said at the top of the program, signs of wanting to give things away, or all of a sudden they're expressing feelings about feelings toward you, and by feelings I just mean like, you are one of my best friends, I love you so much. Those can all be sort of triggers, and I think those tend to be a little bit more common with women. And let's see, we also, I think women are more likely to say to reach out to an auntie or a mom or a friend and say, girl, I need, I need some help. We tend to be a little bit more likely to reach out, whereas I think men, and Dr. Russell Hancock will take this one, but I think men have a different approach in terms of their warning signs or things that you might want to look out for from a male's point of view.
And on that note, I will be the male. So one of the things that Dr. Cochran talked about that I do agree with is that women have the ability to talk about their stuff. One of the things that we as men are not socialized to deal with their feelings. One of the things that I often use with people, especially with men, is that we identify a problem and we want to get to the solution. And it's the stuff in between that we don't want to deal with, because we as men want to find solutions, fix things, but we might necessarily want to deal with what's in between. So that would be the most significant thing that stands out to me about the difference in men and women. Then with respect to the aspect of denial, I'm of the mindset that it's going to be difficult to help someone if they don't want to help themselves. But the other thing that's important too, and this is often the case, is making sure that the person who's given the feedback or who thinks that the person has a concern, make sure that basically that their house is being handled as well. Like it'd be difficult to point the finger at somebody if everything else with me is a mess as well. But again, I think the denial issue it's not easy to address with anyone. Again, I think the stigma comes into it, depending on who the person is that you're addressing. There might be some issues with respect to gender. There might be something with respect to age and how, one of the things that I think is important, and it literally does not fail, is that every family has a communication dynamic. And within that communication dynamic is how we handle and or talk about if there are any concerns within a family unit. And so again, if someone is in denial, again, I think we have to go back to, well, what are they in denial about? Do they see that they have concerns? What am I basing that concern upon? And I think that that's the part that is it's difficult. Is we often want to think that people are now they may not register or they may not recognize what others can see within themselves.
Gotcha.
And I would say that's true too, especially with severe mental illness. So a lot of times what we see is in cases of severe mental illness, people truly, genuinely do not see that there is a problem. They will tend to, they may display some odd behavior or just, I'll leave it at odd or bizarre behavior, but in their minds, it doesn't feel odd or that different, and so I think sometimes what may look like denial may actually be sort of a brain condition that sometimes people are not able to see, how they're presenting in the world or what has actually happened in their brain to create a severe mental illness situation.
It's also important to note that we as people of color tend to be diagnosed with more severe mental illness than we do with things, whereas white women, specifically white women, are more likely to be diagnosed with anxiety and depression. That by the time that people of color, especially African Americans, are diagnosed, they're diagnosed with more severe conditions such as schizophrenia. And that's important because, again, if there's any combination of a dual diagnosis of schizophrenia, substance abuse, it's going to be treated differently. It's going to be handled differently. And I think it's important to understand that clinically, although the symptoms might seem similar, if they're treated differently, then they're going to be received differently. And even the treatment with respect to medication and things like that will be handled differently.
We have a question from Gary Kreitz. He asks, to what can we attribute the significant rise in suicide among Black youth as compared to their non-African American classmates? Dr. Cochran, did you want to jump in?
Actually, I'm going to pass this to Dr. Hancock because Dr. Hancock and I, in sort of preparing for this, he had some really good information that he's researched. So I'm going to pass this to him, and then I will piggyback onto what he says, but I'll let him go ahead and jumpstart.
Translation. No, I appreciate that. So one of the stats that I found is that African American boys between the ages of 5 to 12 have a higher incident rate of suicide than their counterparts. Research does not necessarily identify all the reasons, but one of the things that I think we have to look at is the age of the internet. We have the social pressures. We also have issues related to trauma, substance abuse, sexual identity, and there is an inherent fear what it means to be Black. And so all of those things individually or collectively can cause young boys to want to take their lives. One of the things that's difficult is there aren't a lot of people who look like me, and in this case, look like Dr. Cochran or Fonda, who are professionals to help them along the way. And so it is important to understand that their needs might be different, their challenges might be different, but right now they are being raised in a society that minimizes their self-worth.
Gotcha. Yeah, there was a question about that. One question was, how important are issues of sexuality, especially young people questioning their sexual identity?
I'll just have a quick piece on this. I just think that this generation, their sexuality is more fluid. And so there's not as much of a desire or a need to identify all of the time. And I think for those of us who are of a different generation, we want to put the labels on as a way to define the person. But it's, in my professional experience, the younger generation is just not as bound to that. It's more fluid. There's more experimentation, and the experimentation does not equal to this is exactly who I am.
Gotcha. Maddie Marshall, before I do that, Dr. Cochran, did you want to add anything before we moved on?
No, that was, I appreciate, no, I have nothing to add. Thank you for asking.
There's a question from Maddie Marshall. She asked, are there mental health clinical trials, and who and how does one engage?
There are, I do not have the facts and information about specific ones right now, but I do know that there are, periodically there will be different clinical trials about different, whether it's medication based. I think with some of the clinical trials, it's unfortunately with the way that I guess our health economy is set up right now, I think the clinical trials that actually get funded tend to be ones that are funded by either HMOs, insurance companies, or by and large pharmaceutical companies. So those, usually when we're hearing about some of the larger clinical trials, whether it's depression or anxiety or what we call comorbidities or multiple diagnoses at once, those tend to be funded and supported by pharmaceutical companies. But I guess the long answer is yes, there are some, and I do not have that specific information right now.
Gotcha.
And
Okay, and
another question from Julia Paul. Can programs for Black youth that have social and emotional learning built in help with countering helplessness and suicide ideation?
I think the short answer to that would be yes, but I think it would really depend on the program, and then what's the structure and how is that implemented.
And
Okay.
I guess I would just sort of add that it sounds like that the question was about maybe prevention and awareness. And I think anytime we are discussing prevention and awareness and education and information that's actually helpful and effective, those tend to be, we really want to start at the prevention level, across the board of everything that we're talking about here. Prevention and awareness really have been shown to have the best outcomes, because if we can get the education in and the awareness in at a much earlier stage, then people know how to handle and know how to navigate some of these issues that we're discussing today.
And that's why I say with QPR, suicide prevention training, it is a great training, because Hopewell, the school that I'm at, is minorities. And I cannot tell you how many Black students have signed up to take the QPR training, because I always ask them at the beginning of the training, I said, how many of y'all are struggling, going through something, or somebody that is? All their hands go up. And when they get trained, they are proud to say, I'm a gatekeeper. I know how to help someone. So again, we're not giving youth enough credit either, that they can step in and save somebody's life. They can step in and tell, hey, my friend is struggling, because they can. And that's why that training is so important. And like I said, I'm planning on doing it all summer with youth and adults, that QPR training will help youth. And it's not even just about the training. It gives them a chance to open up and share what's going on with them too. They'll come to me after the training, Ms. Fonda, I'm going through something, I need some help, or can you point me in the right direction? Also, one of the things that I do with students, I had these wristbands designed that I wear every single day, because I knew I couldn't be with them 24 hours a day. So the wristband has the National Suicide Hotline number. It has the National Crisis Text number, and they wear it very proudly. But it's more than just wearing the wristband. They use that information on it. So if we give them the tools from information to help to education, these students can, get educated and learn to help somebody else, including themselves. And it also gives them the opportunity to not to be ashamed to open up that they're dealing with something as well.
Ms. Bryant, you mentioned the National Suicide Hotline. I'm not sure how many people are aware, but the United States of America is moving toward developing an 811 number. Are people aware
The
of that?
988, yes.
I'm sorry, 988.
Yes,
I'm sorry.
988. As a
Yes.
matter of fact, My new wristbands had that in there. It says 800-273 will soon be 988. And I did a documentary last August in the hot sun with PBS, because they're going to be kicking off the 988, and they're doing a documentary, a 90-minute documentary on suicide. And I'm very proud to have been a part of that. And one of the things we talked about was 988. And I'm not sure with both of y'all working at Atrium Health, if y'all have seen my suicide prevention signs up in parking decks. And I took this wristband and turned it into suicide prevention signs, because in that moment, we feel like no one cares and no one understands. And we always, and one of the reasons why we don't come to people when we're suicidal in the first place is because the judgment factor. So when I got those signs put up, I wanted whoever was looking at that sign who might have been in crisis or might have been struggling to know that that person who got that up there understood what they were going through. So it's very simple. You're not alone. Those 3 words mean so much to us when we're struggling, because a lot of times we feel like we're alone, and we know we're not, but that's how we feel. It has a national suicide text and a national suicide hotline, because you're still going to be able to call the national suicide hotline when we go to 988, but it's great to have another piece to help someone who is in crisis. So I'm very excited about it, and I can't wait to see it roll out. And I'm hoping and praying we're going to be able to save more lives because of it.
Thank you, Fonda. Can you actually drop that in the chat? You had mentioned about 988. Can you actually drop that in the chat for the audience to see?
What, the 988?
Yes, ma'am.
Okay.
Okay. And another question from Dr. Gigi Hamilton. Many African Americans struggle with trusting police officers due to killings and deaths that have occurred by their hands. But could you talk a bit about crisis intervention teams where mental health professionals partner with police officers that are trained to address mental health issues?
I will take that, because I actually work with the Charlotte Mecklenburg Police Department with the crisis intervention training, and it is such a we really needed a program like this. It has been I can't remember when it was introduced, but the office Charlotte Mecklenburg Police Department officers, and actually surrounding officers as well, get crisis intervention specific crisis intervention training, so that they are better equipped to be able to manage crisis interventions, mental health issues, and they are also getting some training to be able to distinguish between, what's a mental health emergency or mental health situation versus just I shouldn't say just, but a criminal situation. So there is they're getting that training by and large, but there's also a specialized team that gets dispatched to certain scenes if it looks like there's a crisis intervention with a mental health component.
Gotcha. Someone asked, can you talk about the limited quality resources available for working class families? It seems like the better resources and residential services, i.e. supervised residential services for mentally ill adults, are only afforded to the more wealthy class.
I'll say what one of the resources, and I think a lot of people don't use it, and I talked about this before, is if you work in corporate or pretty much work now, everybody pretty much has an employee assistance program, the EAP. It helps with grief, marital issues, finances, and depending on the company you work for, you can get 3, 6, 9 times visits to go to see a therapist, not just you, but your children, anyone who lives in that household. I stay with my son right now, and through his EAP, I'm able to get 3 visits. So you do have that kind of resource, but a lot of people do not take advantage of it. Also, I will say with organizations like NAMI, my executive director is on here, Gary Kreitz. With NAMI, we do have resources. You go to our NAMI website. You can go on if you have Medicaid or no insurance. You can go through, is it Alliance now? Because we don't have Cardinal. You can go through Alliance as well. Mental Health America has now. Anybody who is affected by the pandemic, and that's everybody. If you live in Mecklenburg or Cabarrus County, depending on your insurance, if you don't have insurance, you can go through Mental Health America to see a therapist up to 6 times free of charge, or your child. So it's all about really just knowing where to go for your resources. So I tell people, go to the NAMI website, the NAMI.org. You can go to the national website. You can go to the state website, NAMI-NorthCarolina.org. You can go to Mental Health America of Central Carolinas. They have support groups. NAMI has free support groups and classes to help. And one of their signature programs is NAMI Family to Family. That is a great class. It's free of charge. It helps someone who has a loved one to better help them and not enable them, but also as a caregiver to take better care of yourself. And with the pandemic and everything online, you can do it from the comfort of your home. So I urge anyone who's looking for resources to go to the NAMI website, go to Mental Health America's website, and click on resources for help.
Let me say this, and to all of you. One of the things that we always do with these events is have a call to action. And one of the call to actions that I want to make is that if you all get me all the information that you were talking about for help that people can go to find help, I will make that available to everybody that attended, as well as everybody that registered, because we're going to send out the recording of this. This was great. And we want to share all that information with everybody that participated in this webinar. So if you get that to me, I'm gonna try to get the have somebody get the recordings out tomorrow, and I will include all of that with it if I can get it by tomorrow.
Gerald, I have also put all of the panelists' information in the chat.
Okay.
Hey, let's do one more question before we call it a night, okay?
Yes, sir, Mr. White.
And this is from Maddie Marshall, who has tons of questions, and we love Maddie. The question is, and I agree, because I'm curious, what's the difference between a psychologist, psychotherapist, and a psychiatrist?
I want to touch that one. We're going to start off with the non-serious answer, and that non-serious answer is money. So that's the first difference. But so the more serious response is Dr. Cochran and I have our PhD in Psyche, which makes us psychologists. Psychiatrists are medical doctors, so they have an MD. They primarily do, with respect to psychiatry, they tend to be more in line with medication management. They are able to dispense medication, whereas Dr. Cochran and I do not have the ability to dispense medication. Also, so that's a psychiatrist. Psychologist is what we do. We tend to focus on cognitive issues, feelings, what's going on with the person, develop a treatment plan, and we walk the person through based on what they bring to us. Also in line with that are nurse practitioners who, again, have a medical background, and then social workers who tend to focus on social work, but they can also be a therapist as well. Generally at Atrium, all of us are identified either as psychologists, psychotherapists, and it doesn't really matter what our discipline is, but with Dr. Cochran and myself, we both are focused primarily on psychology, and that also allows us to do other activities such as psychological testing, interpret that, and then report writing.
Good answer. I appreciate it. I'm sure Maddie does too. All right. So again, we appreciate the questions from the folks who are participating, as well as from the panelists with their answers. Really informative stuff, deep conversations that need to be had and don't happen often enough, period. And especially in our community. And we appreciate your expertise and your experiences to help enlighten us on this subject. So my job is not to take us out of here. So I'm going to kick it over.
And that was powerful. And I hope that it has helped someone this evening. And we, at the end of this now, we have a couple of upcoming events, or maybe one upcoming event with Town Bank, and it will be on business banking. when is it, Linda? I can't see the dates on here.
It is Tuesday, June 21st,
Oh, June
6:30 p.m.
And it's with Yvonne Allman and JT Hasty.
Tasty.
And you can go to our websites to find more information and to register. And I want to thank you for joining us tonight. And I will turn it over to Linda to close us out.
Yes, thank you. This was great information. Once again, I want to thank everyone for joining us this evening. And for those of you all, we are the Charlotte Post Publishing Company, serving Charlotte, Raleigh, Durham, Chapel Hill, and Cary, North Carolina. If you'd like to reach out to us, we had for advertising, donations, podcasts, newsletters, sponsorships. We have many opportunities like this evening as well. Give us a call. Our information is on the slide deck here. And if you are on social media, as you see, we have our handles down below. Please like us, share us, and help us spread the word. And we'd like to thank everyone for attending this webinar this evening on mental health from the Charlotte Post Publishing Company and the Charlotte Post Foundation. We thank you. Good night.